I've had a lot of you in class, but if you don't know me, I'm Chris Robinson. I'm a registered nurse, and I'm the clinical instructor for hospital and nursing home combined. I do some other PRN type work, but today I was asked to do the in-service about feeding and nutrition. And so we're going to start with that right now. There are many things that are going to affect nutrition. I'm going to give you some of those factors. Cognitive abilities to recognize food and to remember how to eat. And to people that are just in the community, they can't, unless they've dealt with somebody with dementia, they have no idea that a person could really just not remember to eat and not recognize foods that they always ate. Taste, a person's own likes and dislikes for foods. Culture, how a person has been raised in their cultural practices. As our society has become more and more mobile, we're seeing a lot of different cultural influences. We see Hispanic food, we see Asian food, you see all kinds of different things that are now part of the mainstream, but it has to be something that's taken into consideration. The state of a person's health. If a person does not feel well, think about how you felt if you've ever had the flu. I mean, that's about the only time I ever didn't feel like eating, but if you feel really bad, it will affect your appetite and you do not necessarily want to eat. If you have trouble chewing or swallowing, people with new dentures, people with no teeth at all, they might have an ulcer in their mouth. There are a lot of things that can affect the chewing and swallowing. Social situation. People often eat differently when they are alone than when they're with friends. I don't mind eating alone at home, but I do not like to eat alone at a restaurant. I don't know about y'all, but it makes you think everybody's thinking you're a loser if you're sitting there all by yourself in a restaurant. And it takes a lot of the enjoyment out of eating, in my opinion. Assessing a resident's nutrition. That's one of the first things we do on admission. Is we are going to look at their overall health. We're going to look at their height and weight. The dietitian, which nursing and dietary have to work together to make sure that the person gets adequate nutrition. But their weight is very important, and it's something that we're going to look at. Keeping them well nourished is going to contribute to things like skin integrity. If you have a resident that has a good body weight, they're well nourished, they're well hydrated, they're much more likely to be able to fight off infection, and they're better to keep from getting bed sores, from decubitus ulcers. I'm sure you guys have all seen those by now. They are to help, good nutrition helps them maintain their overall strength and their ability to walk and their ability to stay independent. It helps them have normal bowel and bladder functions, and they have normal weight and energy stores, which are, all those things are important. We've got to work together to provide the best for the resident. When a person comes in, that's one of the things that dietary does, but we're pretty active in that. If a person comes in and they absolutely hate a certain food, and we don't find that out, and we keep serving that same food, those same ingredients in foods, if not caught early, it can cause them to have a weight loss. We also have people that have religious preferences. They don't eat meat at certain times. They have to eat kosher. There are a lot of different religious preferences that, again, we're seeing more and more of that as our society becomes more mobile. We're going to see people from different places that have different beliefs and different practices. So we have to take that into consideration. Lots of our residents will have changes in their diet as far as, ideally everybody would be on a regular diet. No, I'm sure the dietary department would love that. They could fix the same thing for every person, the same texture, the same kind of seasoning. They wouldn't have to make any changes at all. But we do have to put our residents on somewhat restricted diets at times. We're pretty liberal, and it's important to know that your resident has the right to refuse. If they don't like a certain food, they don't like their tray, what's on it, then we always are supposed to offer them the substitute. And I've heard you guys do it a whole lot. You'll be like, I'll call the kitchen, I'll try to get you a sandwich or try to get you something that you like. And that's good. That's something that we need to do. There are different types of restrictive diets. There's a calorie restricted diet. These will range from 1,200 to 1,800 calories a day, and a lot of times those are ordered or people that come in that are way too heavy that we're trying to get. You have an ideal range. Most of the time we want our people to be well nourished as far as a little on the healthy side, if you know what I mean. But too healthy, too heavy is not good for them either. So they will sometimes put them on a diet that will restrict their calories, and over time it's going to bring their weight down to a more normal weight. No concentrated sweets diets. You're going to see this in a lot of our diabetics. Unless they are extremely brittle, a lot of times our diabetics can just avoid the really concentrated sweets like desserts, and they'll be able to maintain their blood sugar pretty well. No added salt diets. These are for your residents that have high blood pressure, and they're going to get salt substitute, which I'm sure they love, but they get salt substitute. They're also going to have a restricted amount of things like canned soups and canned vegetables, things that have a lot of added extra salt in certain meats. Fat restricted or cholesterol restricted diet. These are for those that are getting into hyperlipidemia. They're having trouble with cholesterol, lipids, that kind of stuff. Heart patients, they're going to have diets like that. Renal diets. These are residents that maybe are in kidney failure, or they can have a whole multitude of problems, but they will be restricted on their proteins, and they're sometimes those are really hard to calculate, but they're fairly restricted whenever they have a renal diet. Things that we can do to make the dining experience more pleasant. Environmental factors. Whenever you go to a restaurant, let's say not McDonald's, someplace like that you're going to be on a date, like date night, or just out with your significant other. You want it to be pleasant. You want it to be, if there's music, I know for me, I don't like blaring loud music. I like background music so that we can visit and we can still carry on conversation. So you want it to be pleasant. When they go to the dining room and they're spending time in there eating their meals, we want them to be comfortable, and we want the atmosphere to be pleasant. So the TV shouldn't be up real loud. There shouldn't be a lot of confusion, which that's kind of a joke. If you've ever been to the dining room, there's usually a lot happening because we don't have a separate activity in dining room, but we do the best we can. Service factors. When you bring your tray to your resident, or their tray to them, be sure to try to be positive. If you look at it, you're like, oh my, you start steady making comments, and this doesn't look good, and you make faces and roll your eyes and whatever. If you don't present it in a positive way, then they are not going to perceive it in a positive way. And sometimes it'll taste fine, but maybe it's puree, so it's not going to be exactly like what they're used to anyway. So try to present it in a positive way. Try to talk it up the best you can to make it good for them. Social factors. If you think about us that are still in the community, everything we do revolves around food. You go to church, you have fellowship after church. You have a funeral, they always have a meal after the funeral. Go to any kind of wedding or shower. Most everything will revolve around food, and they're very used to that, and we need to maintain some similarities. So you want to seat them with someone that they can have a conversation with. If they're able to carry on a conversation, seat them with people of people that can function in a similar way. Don't put somebody that is a wanderer and a pilfer and getting into things and inappropriate in their conversations. Don't put them with somebody that is still able to carry on a conversation and still is interested in being social. But try, when you sit and feed your residents, sit across from them, make eye contact with them, talk to them, try to engage them in conversation, ask them. The thing I've always found is if they have children, ask them about their children. If they start talking about their children or grandchildren, it's usually, not always, but it's usually a good thing, and they will have good feelings about that, and it will enhance what they're doing in any setting. You can also find it if they're interested in something. We were just talking about gardens a little bit ago. A lot of these elderly Southern people, they know when it's garden time, and they enjoy talking about gardens because a lot of their lives revolved around, especially this time of year, revolved around their gardens. So find something that they're interested in, make good eye contact with them, and talk to them about things that they're interested in. Rather than, and we're all guilty of it, but if we sit in the dining room, a lot of times we talk to each other and have our own thing going and they're just kind of listening to us. We should try to engage them in conversation and make it enjoyable for them. When we get ready to set up a tray, and I know you guys probably can tell me about a lot of this stuff, but first of all, when we take them to the dining room, we want them to have all their assistive devices. If they have dentures or glasses or anything like that, they need to have those assistive devices with them and properly put in their ear or on their face, whatever, so that they can use them. And I know for me, like I was telling Allison that I forgot my reading glasses. I wear them periodically. Just when my eyes get tired, I start having trouble focusing, so I wear reading glasses. And I know that when I don't have them and I need them, it drives me crazy because my eyes just keep trying and trying and trying to focus. So think about that. They need their glasses, they need their dentures, they need their hearing aids even to make them at their best where they can enjoy their meal. When you go to set up their tray, from the old days when I first started, it's much different, but am I correct? We take everything off the tray, everything that's in a carton is poured into a glass, and then all of the papers, wrappers, everything that can be removed, and the cover is all removed from where they're eating to try to make it home-like. Also, we need to ask them, do they want salt and pepper on their food? Do they want butter on their roll? Do they want butter in their potatoes? Do all the things that you would want done to make the meal more enjoyable. And I know for me, mashed potatoes and butter go together, rolls and butter go together. You want to add all those things that will make it good for them. If you have a blind person, you need to be sure and tell them, I don't know if you guys have anybody blind right now, but as you're describing the food, you tell them what the clock would be pointing to, the hand of the clock. And you would say, like, 12 o'clock is your roll, 2 o'clock is your mashed potatoes, 4 o'clock is your green meat. So you describe those so that they know exactly where everything is before they start. Ask them what they want first. Be sure and give them a chance to eat. I know when we have limited time, it's hard not to rush them, but allow them time to really eat and offer them lots of drinks in between, and offer them, wipe their mouth, offer hygiene every time that you can to keep them looking nice like you would want to be. Dysphagia. This is a condition that affects chewing and or swallowing. It can be caused by a stroke or head injury, and I know you guys have you've seen a lot of residents like that, where they at one time ate just like you and I, and now they have to have a puree diet where they have to have thickened liquids. And those of you that have dealt with them, you know that a lot of times probably you guys will be really good at catching when somebody is starting to have a problem like that. I'm going to run through a list of some of the symptoms. Coughing before, during, or after swallowing food, liquid, or medications. Having to swallow 3 or 4 times after each bite. Hoarse, breathy, or gurgly breathing. Drooling. A feeling that something is caught in the throat. Pocketing food in the side of the mouth. A repetitive rocking motion of the tongue from front to back. Continuous throat clearing. These are all things that you might notice that would be symptoms of dysphagia. There are some, though, that are silent aspirators. We don't always catch that something's happening, and instead of going to the stomach where it should go, it's going into the lungs. And some of the things that you might be indicators: unexplained weight loss, because it's not going where it's supposed to go, decreased appetite, and a lasting low-grade fever. We need to identify residents that are at risk. Watch for these things. A change in the resident's ability to eat independently, such as the resident needing help to eat or drink. Sometimes we don't realize it's happening, but somebody is really going down. We always talk about their conditions just declining, and maybe we don't catch it right away. But that's a pretty good indicator of an overall change in their ability to eat or drink. Any chewing problems, such as those caused by mouth pain or dentures that do not fit. Once they've lost a little bit of weight, those dentures will be clicking and clacking around in their mouth. They can't get them to stay in right, and then that is going to further cause them trouble with chewing and then more weight loss. Any weight loss, a sudden change in the amount of food the resident eats, such as eating less than half of meals or snacks. Complaints that food tastes funny. sadness, crying spells, or withdrawal from others, confusion, wandering, pacing, or leaving the dining room without eating. Like I said, you guys have an awful lot of experience and probably are very good at catching changes in your residents. But those are all things that need to be reported. Don't just think, oh, it's no big deal. Report those things where we can, if they're starting to get a problem that we can maybe help them with, we catch it early. Dietary supplements. I'm sure you guys, I know the residents get tired of them. We're always trying to, I've had them say, you know, you were just here. You were always trying to get me to eat something. But we're adding Insures, we're adding Mighty Shakes. Y'all help me. I know there's a whole bunch of them that you guys do. Insure pudding. There's all kinds of different things that we're trying to do to up the calories, but not necessarily the volume. We want the maximum number of calories for the minimum amount of volume. Examples of residents who benefit from supplements include the following: those who accept liquids better than food, those who cannot consume large amounts of food, those with an altered sense of taste and smell, and those who are very thin and underweight. I'm sure you guys deal a lot with feeding tubes. A lot of them will, at some point, they've had a weight loss, 5%, they start interventions, 10%, they get more aggressive, and then usually the family, if there's not a living will or advanced directives, then a family member, somebody has to make the decision to put in a gastrostomy tube or not. Once that decision is made, then they calculate the calories that they, because sometimes they can still eat. You guys have probably seen that where they eat during the day, but if they are not adequate enough to maintain their weight, then they add the supplement at night. There's all different ways that they do it to try to keep their weight as good as possible. I forgot my train of thought, sorry. Anyway, I'll go on. Complications may occur from tube feedings. Nauseous, they can become nauseous, vomiting, diarrhea, swollen stomach, constipation or cramping, coughing, wet breathing, or feeling that something is caught in the throat, discomfort or dryness in the throat. At the site where the feeding tube enters the body, they may have pain or redness, crusty or oozy fluid, and sometimes the breath will pull the tube out. If you change from people giving you somewhat solid food, even semi-solid food, to all liquids, you're going to see some changes in their bowels especially. But they may not tolerate the feedings at first. Usually they'll start them on a smaller amount and they'll work up to day after day. They'll increase that amount until they're able to tolerate the feedings well enough. Anybody that is tube fed needs to have the head of the bed elevated at least 30 degrees. And I think most of the time, from what I understand here, is unless they're having care where they have to be flattened out to turn, they're always at, am I right, they're usually 30 to 45 degrees at all times. They need to be, though, at least 30 minutes after tube feeding. If you're ever not here, it needs to be at least 30 minutes. I think they leave them up all the time here. Report immediately any change in the resident's bowel routine. Report any complaint from the resident. Observe the insertion site, and you're going to report any changes in that. Report anything the resident may tell you about the tube. Dehydration. Dehydration is, it's kind of like which came first, the chicken or the egg, because you have urinary tract infections, you've got dehydration, you've got impactions, and all those things impact each other. And we want to keep our residents well hydrated. Things that will affect that are our residents' reduced ability to recognize thirst, the kidneys' reduced ability to retain fluid, a resident's inability to communicate the need for fluid because of their mental status, and then you've got lots of medications that will affect this. You want to look for dry or cracked lips, sunken eyes, dark urine, sudden confusion, more sleepiness, changed ability to do tasks, sudden weight loss, skin on the chest or forehead is easily tinted, decreased urine output or excessive urine output, dry eyes and dry mouth, constipation, frequent crawls, frequent urinary tract infections. All these things are good indicators of their hydration. So to prevent dehydration, we're going to ask what the resident likes to drink and try to have it on hand. And I understand from Allison there is going to be a hydration cart. They started that twice a day, that a hydration cart goes around and tries to offer them anything they might like to try to keep them hydrated.
make sure that they always have their water pitcher, and that's been since the beginning of time, so that's not anything new to you guys. There should always be a water pitcher